Hello, my name is Stefan Windecker from Bern, Switzerland, and it's my pleasure to welcome you to the first ESC Asia Live session, which topics the 2020 ESC guidelines on non-ST elevation acute coronary syndromes. They have been first presented on occasion of the Digital Congress in Amsterdam this year, and they cover an important disease spectrum that affects millions of patients worldwide. It's my particular pleasure to welcome our panelists, who are Jack Tan from Singapore and KW Park from Korea, and Jean-Philippe Coulet, who has been one of the task force chairs of the 2020 ESC guidelines on non-ST elevation acute coronary syndromes. Before moving to the short overview presentation, I also want to remind all participants to use the Q&A forum to send your questions, which we'll be very pleased to address during the online discussion. Now, the first thing we are going to show is a short video which provides you an overview on the non-ST elevation ACS guidelines, and it's presented by Jean-Philippe Coulet.
Since 2015, many changes have came in. So we have implemented all these major changes in these new guidelines. And the first major change relates to diagnosis and the use of high sensitivity troponin over the less sensitive ones. And especially to implement this high sensitive troponin in a new algorithm of 0-1 hour. And this has a major impact, especially in the emergency department, where the use of such algorithm allow to rule out MIs and early discharge of your patients. So this is going to be a major change for emergency physician. The second major point is the implementation of non-invasive imaging, especially during the diagnosis step, because now we have the coronary computed tomography angiography, which allow early rule out of an underlying CAD and avoids also invasive angiography in almost 1/3 of the patients. So this is a major change. Third, I would say that we have also revised the risk stratification for an early invasive approach, and we have deleted the intermediate risk group, and we have mainly simplified the high-risk group. This is mainly non-STEMI patients with high sensitivity troponin or grace risk score above 140, or those with dynamic new or presumably new ST changes. And these has to go to the cath lab within 24 hours of admission. Then we have implemented a new chapter which relates to MINOCA. These are myocardial infarction with non-obstructive coronary artery disease. This is quite frequent, and we have highlighted the key role of cardiac magnetic resonance to identify the underlying cause, and this did not exist before, so it's a major change in these two guidelines. And finally, the two last points relates to antithrombotic treatment. The first one to dual antiplatelet therapy, and the mainstay for the duration is 12 months, but it can be shortened to 1 month, or it can be extended beyond 12 months, depending on the risk. And it can be also modified by switching depth or de-escalation. So there are many different scenarios which have been implemented. And the final point, it's a very important point, it relates to the patients who are in need for oral anticoagulation. And these patients represent 10% of patients with non-STEMI. And we have clearly recommended the use of NOAC over VKA. And then we have also recommended the use of dual therapy, a combination of NOAC plus single antiplatelet therapy for the first 12 months after a very short period of triple antithrombotic treatment of 7 days. So these are major changes as we had before, and this is mainly based on the recent randomized trials. And finally, we have paid particular attention to the layout of these guidelines. And we have implemented the use of short audio recording to guide you through the main figures. And finally, we have created two companion papers with a very small scenery, about 80 in total, which should help you to implement these guidelines in your daily practice. So I hope that you should enjoy these new guidelines.
Thank you very much, Jean-Philippe, for this concise overview on an extensive document. And we will not be able to discuss all of the recommendations, but we have selected a few topics that we would like to start with. And the first one is dealing with risk stratification and the importance of troponin. And I would invite Jack to comment a little bit from the Asia Pacific perspective, the interpretation of the use of troponin in risk stratification. Jack?
Thanks, John. Thanks, Jean-Philippe and Stefan. This publication on a consensus methodology addressing the use of high-sense troponin T, which I led, was quite insightful for me as well. In the Asia-Pacific region, which is very diverse, firstly, there's still a lot of use of CK-MB rather than troponin in certain countries. And the troponin assays are currently not high sense in a lot of countries as well. But in spite of that, recognizing that there's still a huge role, and we are also recommending that patients attending to ED use a high sense troponin T assay instead. Because in Asia Pac, there's still a lot of countries with function on the point of care testing, which is also doesn't follow this algorithm. So for us, a few observations that is different from the current ESC guidelines. This recommendation and flowchart addresses patient attending to ED for a rule out or rule in or observe algorithm for triaging purposes. Doesn't necessarily mean rule out for any underlying CAD. And we are recommending a leeway of 0 to 3 hours, recognizing in Asia Pacific is very difficult for us logistically to function on a 0 and 1 hour turnaround time for high sense troponin T use. We also recognize and endorse the 5 to 52, and in most circumstances, 5 to 70, which is 5 times the upper limit of detection for high sense troponin T. And we also endorse delta change, absolute or 3 if you're using a 0-1 hour algorithm, or up to 0 in the 0-3 algorithm up to a delta change of 5. And in some countries in Asia Pacific, for example, like in Japan, my stakeholders say that if they have someone with an NSTEMI with a delta change of more than 5, they are bringing the patient directly to the cath lab, which is not currently the widespread practice. So thank you for that and the opportunity to share this algorithm.
Thank you, Jack. I think this is extremely helpful because recommendations, they need to be implemented into practice. And we have to recognize that there are differences around the globe and from country to country. Jean-Philippe, any comment on this algorithm from your perspective and how to enable the transition to high sensitivity troponin?
Well, I think that we are very close. So in Europe, about 80%, of emergency departments are using high sensitivity troponin. It is not the case in mobile unit where you still have the regular troponin. But the key message here is to rule out, the MI diagnosis, and to end up with, a very low probability of recurrent events within the 30 months. And this is the main goal of high sensitivity troponin. And we have implemented the 0-1 hour algorithm because it has been tested with many different assays. And we have all the cutoffs which are very safe in terms of patient outcome. So if high sensitivity troponin is not available, on site, we still, of course, recommend the use of the regular troponin And in addition to that, you may also use copeptin, which may increase, the ruling diagnosis of MI. So, but the key scenario is high sensitivity troponin, and it's being implemented everywhere. And I think it's going to happen in Asia.
Thank you, Jean-Philippe. So really, the added value of the high sensitivity troponin is its exceedingly high negative predictive value for unsafe discharge early from the emergency room. Now, we got one question related to this topic, and that is, maybe Jean-Philippe, you can address it. How much increase from a baseline high sensitivity troponin may be considered significant after 1 to 2 hours? So the question directly addresses the 0-1 or 0-2 algorithm.
Well, it depends on the assay you are using. And in these guidelines, we have provided all the assays that are on the market and which have been evaluated in terms of patient outcome. So it depends on the assay you are using, but what we are looking for is first, the first value. If it is very low, you do not need to add an additional assessment, and you can discharge a patient because the probability of MI is less than a few percent, and you can discharge your patient safely. If the level is considered as normal but not very low, then you need to go for the 0-1 hour algorithm. And the difference and the variation depends on the assay you are using.
Thank you, Jean-Philippe. And perhaps another question directed to you as chairperson, which I think is important to clarify, and that is to clarify the nomenclature of non-ST segment elevation acute coronary syndrome, or non-STEMI. Can you shortly comment on this, please?
Well, non-STEMI stands for ACS without ST elevation and high sensitivity positive troponin. But it does not mean that there is systematically an underlying coronary obstruction. So it embraces many other diagnoses, such as MINOCA. And this is very important. And the second key message I would like to disseminate is that there is still, ACS patients without ST elevation and very, severe coronary artery stenosis without, elevation of high sensitivity troponin. So it still exists.
Yes. So basically the unstable angina and non-STEMI under the umbrella of non-ST elevation ACS. Thank you. So let's move to the next topic, and when we move forward on the next slide you see on the screen, I would invite KW Park to discuss a little bit the Asia Pacific classification on bleeding risk.
Yeah, so hi, Stefan. Pleasure to be here. We all know that there are various different definitions of high bleeding risk. One of the ones that are most commonly used is the ARC high bleeding risk criteria. There's also the DAPT score. We have various scores such as the Paris score and the precise DAP score. But I think from an Asia Pacific consensus point of view, want to make this a bit more simplified. And so I think the consensus is to categorize this into an A, B, and O category, where age stands for A stands for age, and then B stands for previous risk of bleeding, and then and O stands for organ failure. So age is patients that are over 75 years of age but are very frail, or 85 years greater, or somebody with a life expectancy less than 1 year. And then previous bleeding would be somebody with a history of spontaneous intracranial hemorrhage. And then because a lot of Asians have GI trouble and GI disorders, recurrent GI bleeding, and then anybody with a hemoglobin that's less than 9 would be classified as somebody who has a significant enough anemia to consider previous bleeding. And then also because HBV and HCV are prevalent in several areas in Asia, we also need to think about the liver cirrhosis, and then also end-stage renal failure requiring dialysis, and then bone marrow failure with platelet count less than 50K, and then stroke in the last 6 months would classify as an organ failure. So I think this is a more simplified binary approach to try to find patients that have higher risk of bleeding.
Thank you, KW. I think this is a very pragmatic and useful approach, and it is interesting to learn from the Asia Pacific region. Now, Jean-Philippe, bleeding risk has taken prominence also in the ESC guideline, and maybe you can share what has been the discussion within your group on the assessment of bleeding risk.
Well, yeah, the bleeding risk in the guideline is assessed very early during the patient care with the ARC-HBR, because it is well calibrated, and it is also well suitable for our population who are undergoing PCI. And I think that this kind of score is very important to assess very early, and it can be assessed very early, because it's going to drive your decision on the intensity and the duration of DAPT. And it is also quite valid for the patients who are in need for oral anticoagulation, who represent about 10%. So we have put a great emphasis on the ARC-HBR, and it is also associated with mortality and the risk of re-MI in these patients who are undergoing PCI. So I think it is, I would say, accurate, pragmatic, and quite easy to use in the real life.
So bleeding risk certainly very important in order to address the intensity and duration of antithrombotic therapy in patients with acute coronary syndromes. And we certainly need to continue on our work to validate bleeding risk scores. And I think we need to be sensible that there may be different bleeding risk scores depending on region and geography. Before turning to the next topic, we got one more question, which I would like to address once more to you, Jean-Philippe. Again, it's related to troponin. And the question is, does it matter which high sensitivity to troponin is done, troponin T or troponin I?
Yes, it does not matter. But you need to know what is a low value, what is a very high value, and you need to know the variation which are associated with the low risk, high risk, or the observed zone. And this has to be determined, in studies where you have outcome data on your patients. And this is I would say, the key message.
Thank you, Jean-Philippe. We are moving to the next slide, and here I would ask Jack to comment on the issue of antiplatelet therapy, and which is displayed here. Basically, the recommendations as they relate to the P2Y12 receptor inhibited. Jack.
Yes, thanks, Stefan. So this guideline was wonderful. This is the latest update from ESC. The thing that in Asia we picked up, and there's currently a lot of debate in Asia, is the movement to recommend against routine pre-treatment with a P2Y12 inhibitor in patients whom we haven't done a coronary angiogram, and early invasive management is planned. I think this has come down to a class 3A recommendation, which implies harm if you do pre-treat patients who hadn't had a coronary angiogram. And I speculate that this change is due to results of the ESCOT, ICER-REACT-5, and the SCAR registry. But in Asia Pacific, a lot of countries are still practicing routine pre-treatment. So we are still grappling with this guideline. So we welcome a discussion around this topic.
Thank you, Jack. I think this is an important topic, keeping in mind how quickly an invasive strategy can be realized. Now, Jean-Philippe, can you comment on the issue of pretreatment from the ESC guideline perspective?
Yeah, well, I would first say that there is some disconnection between evidence that we have and practice. And this is very often seen with respect to timing. This is timing for P2Y12 inhibition, but this is the same for statin therapy and for early angios. So my take on this topic here is that we have, of course, left the door open. And when you do not have the opportunity to have rapid access to angio, and that the probability of, underlying severe coronary artery disease, you still can use, pre-treatments. So it's not definitely, not recommended, but it is just a routine. And this is because, MINOCA is quite frequent, and it represents 1/3 of our patients who are presenting with non-STEMI. So you need to use the right treatment for, the right persons. And we have not been able to show that we can prevent, this small percentage of events, which represent, I would say, 2 to 3% between, the admission to the angio. It's very small, percentage, and it's very difficult to show any evidence that with this kind of treatment we can prevent these heart events.
So thank you, Jean-Philippe. I think it is important to highlight that this recommendation really relates to facilities and geographies where an early invasive management strategy can be realized. And there it is advised not to have a routine treatment. And actually, we just got one question from the participants, and that is, what should we do in countries where invasive facilities are not available in all cities? How should the treatment and the pre-treatment be? Jean-Philippe, you want to comment on this shortly?
Yes, two comments. First, if you think that the probability of obstructive coronary artery disease is very high, and that the bleeding risk is low, and this is what the guidelines are saying, just pre-treat. And the second message is try to use CCTA, which are very helpful to rule out obstructive coronary artery disease in more than 30% of your patients. So if you do not have access to cath lab facilities, you may have access to CCTA, which is highly recommended with a 1B recommendation in these guidelines.
Thank you. Moving to the next slide, KW, one issue is also the de-escalation. Do you want to comment on this?
Yeah, so we could probably talk about this for hours, but I mean, I think in the Asia Pacific region, we're in general agreement with the recommendation from the ESC guidelines. However, some of the issue is that we feel maybe East Asians may have a slightly increased risk of bleeding compared with the risk of ischemia. So the choice of using a de-escalation therapy during the 12 months of DAPT is relatively, I think, more common in East Asian countries than in Europe. And then another issue is the fact that we are building with evidence regarding using potent P2Y12 inhibitors, DAPT for 1 to 3 months, and then going to the monotherapy of the potent P2Y12 inhibitor. So I would like to hear the perspective, the European perspective of, where is the trade-off between maybe de-escalation versus going to monotherapy or continuing with the full dose of the therapy for 12 months.
Jean-Philippe, can you comment on this, please, for us?
Yeah, it has been very difficult to end up with this figure you have on your screen. But the key message here is, personalized medicine. So we have tried to implement, all types of, possibilities according to the randomized evidence we have. And you can see that we advise early to risk stratify the bleeding risk. And if the bleeding risk is high, according to ARC, HBR, or other types, you may use aspirin, clopidogrel, and drop very short, aspirin or clopidogrel because of the bleeding risk. But still, if you think that your bleeding risk is low, and that, during the early phase of PCI, you have any evidence for bleeding, then you can de-escalate. So we have implemented the Twilight, but also the TICO perspective, and you can see that you can have aspirin, ticagrelor, and then drop aspirin, but you can have also aspirin, clopidogrel, and then drop aspirin. So I think that we have paid attention to all this new evidence, especially from Asia, but we agree that the bleeding risk is a bit different.
Thank you, Jean-Philippe. I think it's time to wrap up, and I want to take the opportunity to summarize the importance of risk stratification and of high sensitivity troponin in the diagnosis of non-ST elevation acute coronary syndrome. We also learned about the importance of bleeding risk assessment and differences between Asia Pacific and European countries. We discussed a little bit the issue of pretreatment, where we should probably not pursue pretreatment in areas where an early invasive strategy can be followed. And finally, we discussed the de-escalation therapy with important contributions and studies from the Asia Pacific region, where actually we have several options to de-escalate and also use potent P2Y12 inhibitor monotherapy. I want to take the opportunity to thank Jack, KW, and Jean-Philippe for the engaged discussion. And I also want to thank our participants for asking important questions. And I wish you a fine continuation of this meeting. Thank you.